Hello everyone, and welcome to today's webinar, which is hosted by the FASD Hub Australia. I'd like to start by acknowledging the traditional owners of the lands on which we meet from all over Australia. I join from the land of the Wallumaggadigal clan of the Eora Nation in Sydney, and I pay my respects to elders past, present and future. I welcome all our Aboriginal and Torres Strait Islanders who are attending the webinar today. We note that teaching and learning has taken place in Aboriginal communities for many thousands of years. My name is Elizabeth Elliott and I'm chair of the FASD Hub Australia. I'm a Professor of Paediatrics and Child Health at the University of Sydney, and I head the New South Wales FASD Assessment Service. I also chair the National FASD Advisory Group for the Australian Department of Health. The FASD Hub Australia was funded by the Australian Department of Health in 2016. Its purpose is to raise awareness of fetal alcohol spectrum disorder and alcohol use in pregnancy and breastfeeding, and to be a one-stop shop for evidence-based information. The Hub connects clinicians, researchers, and policymakers with individuals and families who are living with FASD. We run webinars on a variety of topics and provide a repository for Australian research and current policy. Our most popular pages are the Australian Guide to the Diagnosis of FASD, the Directory of FASD Services, and our educational resources. We have recently launched a rebranded website, and I encourage you to visit and take a look at fasdhub.org.au. We welcome your feedback and suggestions for additional topics or content. And now I want to introduce our expert social workers and guests for today, Kerryn Bagley and Julia Perl. Welcome to both of you and thank you for attending. The purpose of today is really to acknowledge the very important role of social workers in supporting families who are living with FASD, especially through the assessment and diagnostic process. The social worker can identify families and individuals at risk of FASD, connect with schools and local services, alert the assessment team to relevant social and family issues, and provide practical and emotional support throughout the assessment process and after diagnosis. I'm now going to briefly describe FASD to you. We will then hear from Kerryn and Julia, and then we'll hear from a mother who's raising a child with FASD. Then there will be time for questions. So please use the Q&A tab, not the chat function, for any questions that you have. This webinar will be recorded, so you will be able to watch it again later. So just a reminder, many of you will be familiar with fetal alcohol spectrum disorder, but just to remind you, this is a potentially preventable disorder because it is caused by prenatal alcohol exposure. Alcohol readily crosses the placenta and may cause a brain injury in the developing embryo and fetus. This results in characteristically severe neurodevelopmental impairment and may result in permanent disability with lifelong consequences. Quite often you will hear that there is a reproducible pattern of facial features that may be associated with alcohol exposure, but we know that this occurs in only 1 in 5 children with this diagnosis. Similarly, birth defects, microcephaly and growth failure may occur depending on the timing and the dose of the exposure to alcohol. We believe that the prevalence of fetal alcohol spectrum disorder worldwide is about 1 to 4% in the general population, but acknowledge that there are high-risk groups: children in foster care, children in juvenile justice, and children in some remote Aboriginal communities, and this applies worldwide. Now, social workers, as I've said, have a key role in identifying children at risk and supporting families towards and beyond the diagnosis. How do we make this diagnosis? We confirm prenatal alcohol exposure, usually using a standardized tool such as the Audit C. We do a multidisciplinary assessment of a range of domains of function. And to make the diagnosis, we document severe impairment in at least 3 of the 10 domains that we assess. As I've mentioned, we look for facial features and birth defects and growth deficits, but these only occur in a small proportion of children. And of course, it's important to diagnose comorbidities, other diseases that might coexist. This is really a diagnosis of exclusion because we don't have a diagnostic test, so we also exclude genetic disorders. And it's very important in these children to document whether they've experienced any postnatal problems such as head injuries or meningitis or trauma. And trauma is a common factor in these children. So these are the neurodevelopmental areas we assess, and perhaps some social workers may not be familiar with all of these. Motor skills, IQ, language, academic achievement, memory and attention. Executive function is the ability to plan and conduct complex tasks. Affect regulation is mood and presence of mental health problems such as anxiety and depression. And adaptive behaviour really describes the capacity for self-help skills, for social skills, and for social communication. Just to give you a brief snapshot of what we know from our national data on FASD, and these are cases reported by paediatricians from all over the country. The average age of diagnosis is in early primary school. There is a predominance of males, and there's a significant overrepresentation of Indigenous children. There's also an overrepresentation of children from Western Australia and from remote and very remote communities. Only 1/5 of these children live with a biological parent, and 1/5 has an affected sibling, suggesting that we as health professionals have missed opportunities for recognition of FASD and prevention of an additional child being affected. 75% of these children have had contact with child protection services, and many of them will be in your social work practices. And the majority of them reported to this national scheme had high-level alcohol exposure, and many of them had exposure to other drugs such as cannabis, nicotine, and illicit drugs. So before we progress now, I'd like to introduce a family to give us a bit about their experiences of supporting a child with fetal alcohol spectrum disorder. So in this short video, you'll hear from Melinda and Charlie. Melinda's adopted daughter, Charlie, was diagnosed with fetal alcohol spectrum disorder at the age of 4. And in this video, Melinda will share their story, including why she sought assessment for fetal alcohol spectrum disorder for Charlie, some of the challenges that they face as a family, and her hopes for Charlie's future. It's a really beautiful video, and we do thank the family sincerely for sharing their story with us.
Hi, my name is Melinda. This is Charlie, and she's 8 years old. Charlie cried consistently. It didn't matter what we did to soothe her. She was just never a settled baby. She had quite a large forehead, which worried me as well. We went to our local paediatrician. Actually, FASD was one of the first things that he mentioned. So I was really shocked. I knew that you shouldn't drink while you were pregnant, and that was it. I didn't know anything else. I didn't know the impact that it had on the baby. I don't think Charlie understands her diagnosis at all. You can have the same conversation with her numerous times and she will forget it within 10 minutes. Then you say, oh, Charlie, that's part of your brain injury, and she doesn't. She actually will say to you, I don't have a brain injury. I don't have FASD. So she's at the point of not accepting it at the moment, but she's only 8. So I don't expect her to. So I think getting the FASD diagnosis for Charlie, the school, for family, for friends, it's been more us being more understanding and accepting of Charlie. And I think for our families as well, that she wasn't just a naughty kid, she wasn't just having tantrums, it's actually caused by a brain injury. Like, it changed the way that I parent. You know, I compromise, because if I have just a firm no, then that's not going to work. Charlie has lots of strengths. She's very compassionate. She's great at drawing. She's very flamboyant in the way that she will, you know, she makes up songs and she tells us stories before bed, and she'll dance, and yeah. My advice to anybody going through a FASD diagnosis is that knowledge is power. The experience we've had with sharing our FASD story with school, doctors, family and friends have been really supportive. They've been really good. We've been able to build some really good friendships with people as well. We also have my goddaughter Katie, who is Charlie's BFF. They're ride or die together. She totally understands Charlie and she's a good support to us. And we also have our family and friends. I have a lot of worries for Charlie's future. I worry about her living by herself and being able to, you know, maintain what we would call a normal lifestyle, a neurodiverse lifestyle. And that could be something as simple as remembering to take the rubbish out or remembering to take her tablets. Don't judge somebody because their child has FASD. It is still seen as a taboo subject. To the Melinda 4 years ago, you will find the strength to go on, even in your hard days, and it is worth it, so don't give up. So Charlie, you will achieve the most amazing things. You just need to put your mind to it, and we will always be here to support you, and we love you unconditionally. And that's it.
Thank you again, Melinda and Charlie, for sharing your story with us. And now I'd like to introduce our first speaker, who is Dr. Kerryn Bagley, a senior lecturer in social work at La Trobe Rural Health School and a researcher at the La Trobe University's Living with Disability Research Centre. Welcome, Kerryn. Kerryn's research investigates how mainstream services and systems can be made more inclusive of disabled people, and it has a focus on professional responses to fetal alcohol spectrum disorder in health and social care. Kerryn has actively worked to build the capacity of services and systems to respond to fetal alcohol spectrum disorder in Australia and New Zealand. Welcome, Kerryn.
Thank you, Elizabeth. So a good starting point, I think, when we're talking about FASD is this, that people with FASD can thrive when their strengths are recognised, when their needs are met, and when they're appropriately supported. Next slide. But we know that social workers often come in contact with people with FASD or suspected FASD because there are behaviours of concern, parent stress, issues with peer relationships or developmental concerns. And we know from research that young people and adults, because FASD is a lifelong condition, that those people as a group experience really poor psychosocial outcomes. So what do we make of this? Are poor outcomes just part of FASD? No, they're not. But this gives us a really good indication that people with FASD as a group face disadvantage, and it gives us insight that they're not getting the support that they need. Next slide. So in social work, we draw on research, but we also draw on a range of theoretical frameworks to help us to understand the complex challenges that people face. And today I want to draw on disability theory to help us consider the barriers that people with FASD faced and how we might respond to them as social workers. The critical realist model of disability recognises that there's different ways of viewing disability. So the medical model of disability views disability as a problem that resides with the individual, caused by physical, sensory, or cognitive impairment. And the focus is for the disability to be managed through intervention and treatments. And we know that a lot of kids with FASD, for example, will go and see an OT to improve functioning in lots of different areas, or might go and see a speech language pathologist, for example. The social model of disability views disability as the result of the interaction between people living with impairments and the environment or society filled with physical, attitudinal, communication and social barriers. So in the social model of disability, it's the society that creates disability for people with FASD. So if we have a look at this picture here, according to the medical model, this person experiences disability because of their physical impairment. They can't climb the stairs. But according to the social model, it's the stairs that are creating the barrier to inclusion. The stairs are the reason that the person can't get to the next level. And if we were to replace those stairs with an accessible ramp, the person would still have an impairment, but they wouldn't be disabled by society. Next slide. So the social model of disability is really useful because it starts with us. It starts with us as a community, and it starts with us as the people around the person with FASD. And it asks us, what can we do? How can we address barriers that marginalise people with FASD? How can we best support people with FASD and their families in ways that account for their brain differences, their neurodivergence? And how can we do that across, you can see a little image here hinting to the ecological kind of systems model. So how can we do that at an individual level, but also within the services and systems that support people with FASD? So I'm going to highlight 3 disabling barriers for people with FASD, and I'm going to suggest what we might do as social workers to address these issues. Next slide. So the first disabling barrier is professional knowledge of FASD and our ability to respond. There has been a huge amount of research on professional knowledge of FASD, and you can see some examples up there. But essentially what the research shows us is that professionals as a group across the board have very limited understanding of FASD, and they commonly don't feel confident to support people with FASD. And we also see that in the research on lived experience, particularly with parents and carers, but also adults with FASD, where they feel like professionals have not listened to them or taken them seriously, that professionals lack professional understanding of FASD and what to do. And they often report that they're referred from one professional to the next. Next slide. So what can we do as social workers? Well, a key thing we can do is make sure as social workers, as a group, that we are FASD informed. So this presentation today is an hour. It's not going to give you all of the information about FASD, but we have some fantastic resources out there. The FASD Hub, which Elizabeth Elliott had mentioned, and also the No FASD, which is the National Organisation for FASD, has a fantastic website, including a range of training resources that are relevant to social workers. We're actually really lucky that next month is International FASD Awareness Month. So there's going to be a huge number of different webinars and resources launched that you can get hold of. And you'll also have the opportunity, if you go to some of those events, to listen to people who have lived experience, because they are our greatest teachers. I think another thing to consider is that in the research that I did around professionals' knowledge of FASD for social workers and mental health workers in particular was that all of the social workers thought that FASD was really relevant to their practice. However, and possibly because they didn't have a good understanding of FASD, they thought that maybe while it was relevant, there was somebody else who had a lot more knowledge than them. And we also see this across the board in lots of professions, that other professions assume that other professionals will know more than them. So it's really important to consider whether a referral is actually going to be helpful. If you come across somebody with FASD or suspected FASD, don't assume that another professional will know more than you. It's really important that we all become FASD informed. And also advocate for neurodivergent informed training approaches in your service. People with FASD and neurodivergent, as are people with autism and a range of other conditions, and training and approaches that understand brain differences are relevant for a whole range of people. Next slide. Another significant barrier, often the elephant in the room, is stigma. And we can see here in this newspaper article that stigma around FASD is perpetuated in so many ways. Flood of booze babies hits the NDIS. And this can be a really disabling barrier to people seeking support for FASD. And women often disclose, when they disclose alcohol use or raise FASD, they're often dismissed by professionals. And I think one of the reasons is that professionals are often concerned around creating stigma around FASD, and that's a barrier to them identifying and supporting people with FASD. Next slide. So it's really important to remember that FASD occurs within a sociocultural context where alcohol consumption is normalised. There may be many reasons why a fetus may be exposed to alcohol during pregnancy. Many women don't know that they're pregnant when they're drinking. Some women have alcohol dependence. So it's really important as social workers that we challenge narratives of personal responsibility and punishment. Alcohol causes FASD, not women. As social workers, we're aware of our own personal experiences and perceptions and how they influence how we view the world. And in our study on social service professionals' responses to FASD, professionals often talked about their own experiences of alcohol and pregnancy. So it's really important to critically reflect on how this may shape our approaches to FASD, particularly if we're feeling reluctant or uncomfortable to ask about alcohol use or to talk about FASD. FASD is often conceptualised as a First Nations issue. It's not. FASD affects people across all communities and demographics where alcohol is prevalent. And it's important to recognise the impact of colonisation and ongoing systemic racism and how that relates to alcohol use. Aboriginal and Torres Strait Islander people have been leaders in responding to FASD in Australia. And so I really encourage you to have a look at the strong born resources that have been developed recently on the NACCHO website. And finally, it's really important that we learn how to sensitively and confidently ask people about alcohol use during pregnancy and know where to refer them for FASD assessment. And there are some really good resources on the FASD website about this. Next slide. Finally, my third barrier is neuro-normative approaches to intervention and support. Often we're referred people with FASD to work with because they're facing challenges or behaviour concerns. But a key challenge for people with FASD is that many standard intervention approaches are not effective for them because they're based on normative neurotypical assumptions about behaviour and they don't consider the person's brain differences. So, for example, we expect that people will be able to link their actions to consequences, and we assume that they will be able to remember those consequences for next time. And this is why we often put in place consequence and reward-based approaches to parenting, and we draw on CBT-based approaches to behaviour change in our practice. But many people with FASD have challenges linking cause and effect, and they have challenges with memory, and that's part of their impairment. It's really important to recognise that approaches that don't consider those brain differences can actually cause harm. Often professionals will have let's see if this kind of works approach if they're not sure what to do. But people with FASD are often misunderstood, and they're often misunderstood across a huge range of contexts. You know, the video indicated that the mother in the video had really changed her parenting approach since she understood FASD. But we also see that kids will often have challenges in the school environment. They'll often have challenges with their peers. And if we add to that, they often are, I suppose, engaging in supports that don't recognise their brain differences, that can create chronic experiences of failure. So it's not surprising if we go back to that original slide around poor psychosocial outcomes, that so many people with FASD have poor mental health outcomes. Frustration, negative self-image often translate to defensive behaviours, and they're often the things that we are referred to work on, but they're actually often symptoms of that chronic experience of failure and relate to poor psychosocial outcomes. Next slide. So what can we do? Consider brain differences and adapt approaches to intervention and support. Ask ourselves, you know, what does the brain have to do to understand and process our task or request or intervention? Reframe our thinking about people. Is it that the person is lazy and unmotivated, or do they have difficulties with planning and organisation? Is it that they're attention seeking, or do they have challenges with impulse control and self-regulation? Is it that they're being willfully defiant, or are they frustrated and challenged? Are our expectations realistic? And how can we adapt the environment so it's a good fit for the person? As social workers, our role is both to support individual families, but also challenge the circumstances that create inequity for people with FASD. And I hope that some of these kind of strategies and thoughts around the social model of disability are helpful when you are practicing with people with FASD and their families. Thank you.
Thank you, Kerryn. That was really an excellent presentation, and I'm sure many of you in the audience will have questions for Kerryn, so please put your questions in the Q&A function. And now I'd like to introduce our next speaker, Julia Perl. Julia is a senior social worker with a passion for working alongside children, adolescents, and families with psychological vulnerabilities and complexities. She completed an undergraduate degree in social work and a master in social work counselling at the University of New South Wales, and has now spent 15 years working with clients in community mental health and paediatric disability settings, in inpatient and outpatient settings, in women's and children's healthcare settings, to provide therapeutic counselling and care and management of families across the lifespan. Julia has particular interests in the perinatal period, in family and domestic violence, substance use and child protection, and she currently works in the CICADA Centre at the Children's Hospital at Westmead in the New South Wales FASD Assessment Clinic. Welcome, Julia.
Thank you, Liz. All right, so I'm going to have a little look here at the role of the social worker within a FASD service, but make sure that it's transferable information for any social worker in any clinic. So my role, you know, is refreshingly quite diverse and flexible in order to meet the family's needs. Typically at intake stage, the social work priority areas are sort of families with complex psychosocial backgrounds, current child at risk concerns, and children living with their biological parents. The initial sessions that we provide focus on the completion of a comprehensive psychosocial assessment with the parent or the carer, and that is always inclusive of that antenatal period, that pregnancy time. Whilst children are being assessed by our multidisciplinary team members, the social worker role can also provide a kind of reflective debrief session and counselling with any member of the family who requires it in kind of tandem with the assessments. Short-term case management is also quite imperative in this role, where we assess the family's circumstances as a whole and we collaboratively work out the most holistic management plan for the household. Research and referrals embedded in the local community where that family resides is important. Families who access our service are from across the whole of New South Wales, and I really want to acknowledge that regional and remote areas are not well set up with services, and so it requires very creative solutions from social workers around how might we set up support in a local area for a family. Child protection reporting is quite a frequent part of the role, with mandatory reporting obligations explained fairly and transparently with families up front. We liaise with services and existing supports, in particular schools and counsellors, as a sort of contact point for discussion and comprehensive handover. Of course, the navigation of NDIS is challenging for most, and we can provide additional appointments around, access request forms and whatever else might be required. We provide psychosocial consultations with any sort of team member that's already working or planning to work with a family. We convene a multidisciplinary feedback session, and this is typically where the neurodevelopmental domains assessed are discussed in detail. And if the child meets criteria for FASD, the diagnosis in this setting is delivered. This meeting is understandably very sensitive, requires thoughtful planning from us in the delivery of the information, as well as is the sort of attending to the emotional reactions of the child or that the family might express. In particular, post-diagnosis and beyond, follow-up care in this space is definitely recommended if one has capacity to. Often for families, a need for a debrief and some more formalised counselling arises after the family has received the diagnosis and the associated diagnostic report. Families often talk about a sense of relief mixed with a sense of overwhelm, and social work follow-up at this point is significantly beneficial. On quite a practical level, support such as going back over the report itself, often 20 pages or more, the reviewing of the management plans and recommendations on that report, the talking about any sort of grief associated with the diagnosis, all of that is very beneficial. At any time through the family service journey, we're recommending to link in with the FASD Hub and to contact the No FASD helpline for consultation and advice, so families really broaden their support networks beyond our team. In light of there being one social worker on our team at this time for a New South Wales wide service, intervention is always time limited but flexible, and local referrals always for me are a priority. Next slide. A note on substance use screening. So in terms of clinicians working alongside any families, I sort of have a sense that they're very well positioned to screen children for prenatal alcohol exposure, and that clinician can spearhead the process of accurate diagnosis and the coordination of care necessary to improve health and psychosocial outcomes for children with FASD, as well as their families. What we know is that disclosures happen anytime, but especially in the context of a trusting relationship. Being well prepared as a social work clinician to equip yourself for a detailed conversation about substance use in pregnancy, which will best advocate for the child's needs as they grow, and regardless of the child's age, asking is important. What we know is that the relationship established between women and the social worker will really influence her willingness to disclose alcohol use, and hence healthcare workers should seek this information always in a sensitive and empathetic manner. Trust and emotional safety leads to disclosures, and we know a judgmental attitude does not. Next slide. Next slide, please. In terms of substance use in pregnancy, what we know is some birth parents are open and able to access drug health intervention, and they themselves can make very positive changes in reducing and safely managing their substance use once they're pregnant. But we also know that many women will not be able to stop their substance use, which of course naturally is a child at risk concern, but it's also a health concern and requires a health response. There are numerous systemic barriers existing for women, but in particular in regional and remote areas, such as drug health services not being accessible. Substance use in pregnancy and parenting teams are fabulous, but not always provided in remote areas. Evaluating the myriad of consequences that substance use has on a child's development is in itself confronting for birth parents. Creating a trusting space for those difficult conversations, for me, is really important. Allowing grief, guilt, shame to be well aired. Next slide, please. Just some thoughts on engagement. Acknowledging a woman's experiences and feelings, always with sensitivity and compassion. We must also, which Kerryn touched on, the understanding and reflecting on our own personal values and how they might influence how we interact or talk about a particular topic in our social work profession. We must create an environment which is safe, private and confidential. We acknowledge that drug and alcohol use during pregnancy is particularly difficult, but especially for Aboriginal families and those that are culturally and religiously, linguistically diverse. Naturally, all fearing a child protection response. We need to be aware that drug and alcohol use occurs always in a context of other health, family, cultural and psychosocial factors. And we understand that there are numerous barriers to women accepting care and addressing this care. And we know geographical location or stigma are two of many. Next slide. A little thought about family contexts and trauma. Trauma, including intergenerational trauma, is strongly associated with problematic AOD use. We know adverse childhood experiences demonstrate a strong link between childhood traumatic events and adverse health outcomes, especially including mental health and drug and alcohol use. Aboriginal people in particular have been subject to an array of traumas from the time of colonisation to our present day. The historical legacy of dispossession and forced removal policies, as well as the continued interconnected issues of cultural dislocation, personal trauma, and the ongoing stresses of disadvantage, racism, alienation and exclusion, continue to contribute to a higher risk of problematic alcohol and other drug use. A couple of key resources that I recommend. There's a newly updated clinical guidance for the management of substance use in pregnancy, birth and postnatal period, updated in July of this year. It's a recommended paper. A second one is the National Drug and Alcohol Research Centre. They've done a sort of a deep dive into parenting, into the context of substance use. I highly recommend it, both easily accessible online, and we'll share the links. Next slide, please. To promote better outcomes for people with FASD and their families, there is a crucial need for clinicians to not only recognise FASD, but also to actively address the FASD-related stigma in families and in society in general to promote a strength-based family engagement across that lifespan. We must ensure that FASD diagnostic processes themselves don't increase guilt, frustration or hopelessness, and we must address openly feelings of shame and associated parental grief and depression with respect to raising a child with FASD. I hold Susan Roos's definition of chronic sorrow in my mind when I work with a family. She talks of a grief response to a non-death related loss. She talks about the chronicity of feelings that differentiate chronic sorrow from other types of grief, a living loss, where it's requiring a grieving person to continuously readjust their life, something important to hold in mind when working with birth families. Next slide, please. In terms of parent and carer supports, Prioritisation of peer support groups with other parents and carers who are also raising children with FASD is essential. Families Linking with Families is an online support group through No FASD, and this is a lifeline for families across New South Wales and Australia. Ensure that your referrals are thoughtful. A generalist parenting support group you need to have a sense that it is able to be tailored to suit the needs of a child with FASD. Otherwise, we're sending a family into the wrong place. And always consult the No FASD helpline and the FASD Hub for support. Thank you.
Thanks so much, Julia, for a fabulous presentation. Again, very comprehensive. Now, we do have some questions for both of you. And I might start with one that is perhaps a positive note. Can you share with us some positive stories about the response of someone with FASD once they've received a diagnosis? Perhaps we'll start with you, Kerryn.
Getting me to think back to my practice experience, which was a little while ago. But I think overwhelmingly I can probably generalize that that a diagnosis of FASD really helped families better understand the needs of their child. And until we understand how our brains work and the differences that we might have, it's really hard to put in place the right supports. The reality is we live in a neurotypical world that's set up for neurotypical people. And so when you're living in that world with a neurodivergent brain, it can be really, really challenging. So I think often a diagnosis is the pathway to understanding, support and advocacy. And if we can just, I suppose, increase our knowledge of FASD across service systems and have really good FASD neurodivergent-informed workforces, then that's when we can really see people thrive.
Thanks, Kerryn. And Julia, can you give us an example of a positive outcome of a child and family receiving a diagnosis?
I think a lot of families aren't aware that with a FASD diagnosis, you subsequently meet criteria for NDIS funding, that it's considered a lifelong disability, and that opens up doors to accessing the early intervention that perhaps they've been desperate to access but haven't been able to afford or know they needed, or whatever the scenario might be. So I think that even with all the complexities of accessing NDIS, I think it is a definite door opening opportunity. And the kind of ripple effect of that is the supports and intervention that can be provided in school, and the tailoring of the intervention to being FASD specific, not just for kids with additional needs and sort of not meeting that criteria accurately.
Thanks, Julia. And that answers one of the questions in the chat. Is there NDIS support for FASD? And yes, that's one of the biggest benefits to families of having a diagnosis, documenting their needs and also their strengths, and being able to articulate that to NDIS. Now, there's a comment here, there's an exceptionally long waiting list to get into Westmead Hospital. And I think this applies to any of the clinics. Perhaps I could just answer this briefly, that yes, this is why we're trying to build capacity in a whole range of health professionals, such that social workers and other allied health professionals, psychologists, other medical specialists can all play a part in gathering information that will contribute to a diagnosis. And the more information we have when children are referred to us at our specialty service, then the quicker we can make that diagnosis. And sometimes we can do that even during a case conference with the referring doctor without seeing the child, if a range of assessments have been done. Now, there are a couple of questions here about the sort of tricky issues that we all face about resistance to the diagnosis. So can you make the diagnosis without the birth mother's confirmation that she used alcohol while she was pregnant, even if there's evidence that that did occur in the medical notes, in the child protection notes, or other? Well, perhaps each of you would like to have a go at answering that question. Julia.
Sure. So look, what's tricky when a mum denies is that, you know, it's an asset to be able to talk to a birth mother about her own drinking behaviour in her own pregnancy. That is the ultimate returning to the source of the information. At the same time, if there is substantiated evidence, say in police records, that indicates that she's been in a car accident, noted to be pregnant, and has had a breathalyzer review, or child protection notes that indicate a specific caseworker has visited and observed her heavily intoxicated and pregnant during the 9-month window, that evidence will be considered. But where a mother denies, my understanding, Liz, is that if she's involved in that child's life and she's actively denying them, we can't diagnose. Is that correct?
Well, we prefer not to if the child
Prefer
is
not to,
in the family. But from a pragmatic point of view, the assessment is a really important part of managing this condition, and that assessment gives the school and the parents and all the health workers an idea about that child's capabilities and their needs, and they can be addressed regardless of whether or not there is a diagnosis of fetal alcohol spectrum disorder. And on that note, we also, even when we make the diagnosis, we say very clearly to parents, and they're often foster parents, not biological parents, that they may or may not choose to use that label when they're communicating with the school or with other professionals or with others. So it really gives them that understanding, but that personal choice as to who they share that diagnosis with. Kerryn, would you like to add anything to this point?
I was going to jump back to that previous question, if that's okay, around diagnosis and access to diagnosis, because we know in Australia across the board, access to diagnosis is really tricky. There are not a lot of options for adults, for example, with FASD at all. But we don't need to have a diagnosis in order to ensure that our approaches towards people with FASD are appropriate. It's if you're putting in place interventions and approaches and they're not working, that's a really good indicator that maybe they're not appropriate for the person. So it's really about understanding, you know, what are the drivers, you know, of the behavior, and are we talking about brain differences here? What do we see? What's potentially underlying that? You know, carefully observing how people are interacting and the experiences that they're having, and then kind of working backwards to think, you know, if we're talking about a brain difference here, how might we change our environment so that we can best support the person? And we can do that without having a diagnosis in place or while we're waiting for a diagnosis. And I think that that's really, really important, because there are real risks around kind of people with FASD having lots of kind of negative experiences and lots of negative feedback throughout their lives in different areas. And we really want to make sure that our responses to them are neuro-affirming, so that, you know, so that they do experience good mental health throughout their lives.
Thanks, Kerryn. Now, there's a question here from someone who works in rural New South Wales, wondering whether trainee GPs receive specific FASD training. I can't answer that question, except that I know that there is a demand for such training. And really, if you are working as a GP, it'd be great if you could advocate to the College of General Practitioners to incorporate it into the training. We believe it should be in all health professional training. Now, Kerryn, there are a couple of questions here which you might like to address from New Zealand. One is saying it's not uncommon for grandparents to raise their moko or grandchildren with FASD. What does that look like for this group in Australia? And a second question related, could you talk about your experiences in New Zealand? How does it, I guess, compare, contrast to here?
Some people knew that I started my FASD journey in New Zealand when I was working as a social worker in child and adolescent mental health. And at that point in time, there weren't any services for FASD in New Zealand. And that's been part of my strong journey, is to complete a PhD on how we actually respond to FASD, how we support families. I haven't been in New Zealand for a long time now. I've been in Australia for about 10 years. But I think that the experiences for parents and carers are quite similar. There are a lot of people with FASD who are living maybe with grandparents or non-biological parents. But there are also quite a lot of people who are living with their biological parents. And I think it's important when we're thinking about FASD that we reflect on who's coming to our attention when we're getting referrals to diagnostic services and why they might be coming to the attention. Children who have been engaged in some way in the child protection, child welfare systems are possibly more likely to be flagged as having neurodevelopmental concerns and maybe referrals for FASD. But, you know, kids with FASD are living in a whole range of, different family and kinship care and formal kind of care environments.
Thanks, Kerryn. Now, a question for you, Julia. Any practical tips for supporting a child when they're dysregulated? What sort of strategies might work?
I think simplicity is quite important. Thinking about your own sort of body language and your tone of voice, the amount of words that you're using, the importance of remaining calm, saying less when perhaps you want to say more, keeping the child really safe whilst they need to express themselves in the way that they need to. And I guess not feeling like words are even appropriate whilst they're, going all the way up to 100, supporting them gently to come back down to 0, and then having an opportunity only then to kind of consider very simplified and calm way of understanding and explaining and talking through what's happened. But just making sure that any communication is, really targeted at the level that the child can understand in that heat of the moment, and also once they've come back down in a way that they can manage and compute. And so that requires a kind of tailoring it to the child in front of you and not one size fits all scenario.
Thanks, Julia. Now, there's a question which I'll quickly address here. Is it true that a FASD diagnosis can't be made unless there's evidence of alcohol consumption during pregnancy? Well, we do like to have evidence of alcohol consumption during pregnancy, but there are some exceptions. So if a child has 3 of the characteristic facial features which we see associated with alcohol, and they have severe neurodevelopmental impairment, we certainly do consider that diagnosis. There's another question here for both of you. Any suggestions about how to navigate around working with child safety officers who brush off suggestions for a FASD assessment due to their personal view that it would be too hard to get mum to participate in the process, despite the fact that other family members have verified alcohol intake? So I think there are 2 questions there. We've addressed that second one of what if mum denies it, but what about the suggestion that from child safety officers that mums won't participate in the assessment process? Julia?
That's a big generalisation about all mums. I don't think that that's fair. I think that there's a lot of mums that really want the best for their children, even when they have child protection involvement, and absolutely recognise that substance use in pregnancy may be contributing to their child's complexities before them. And so I think, it's worth not giving up on the conversation and supporting child protection workers to understand that, not all things can be explained by trauma or exposure to trauma. And I think that FASD is often at play in tandem with traumatic events that have happened in that child's life. And the more we kind of use opportunities of resistance to provide education and support to our fellow colleagues and clinicians that we work alongside, the better.
Great, thanks. Did you want to add to that at all, Kerryn?
I think the reality is that often birth mums are concerned around stigma and the possible implications of talking about their alcohol use during pregnancy, even more so probably if their children are involved in child protection. So considering that, and thinking of, ways that we can support people is really important. But also we know that, within this environment where FASD is quite a stigmatized issue, that asking about alcohol consumption during pregnancy and asking about FASD, it may take, a couple of different opportunities and different times to approach the conversation with parents, recognizing that kind of stigma is often there before they may be, and for them to really understand the process of diagnosis and what that means and what the outcomes and what some of the more positive outcomes can mean for both them and their child before people are willing to talk about their alcohol use. And I think that that's really understandable and that we need to allow that space and time for people.
Great. Now, look, we're just about to wrap up. There are a couple more questions just in response to the first. Yes, we do consider the cultural context of children, including Indigenous children, when we're making FASD assessments. I think Kerryn referred to the Strong-Born resources, and I urge you to have a look at those. They've been developed by Aboriginal people for Aboriginal people. And the second question is about co-diagnoses. A lot of children come to our clinics with a diagnosis of autism spectrum disorder or ADHD, and they may certainly be part of the whole FASD spectrum. The question is, why are they diagnosed late? And it's partly because people are reluctant to make the diagnosis of FASD, partly because they don't consider it. So we would certainly urge you to consider it in any child with a neurodevelopmental problem as a possible source of not only FASD, but ADHD and ASD as well. So look, I think we'd better wrap up there. And I really want to conclude by thanking you all for attending and for those very tricky questions, and particularly to thank Julia and Kerryn for your roles as speakers today. It's been a very stimulating session. I'd also like to thank Kate and Kim, who are working behind the scenes for the FASD Hub Australia in putting this webinar together. Just to remind you, there will be some resources posted in association with this webinar, and it will be available online. And within a couple of days, we will send you a link. And we would also very much appreciate your feedback on the webinar, how it could be better, and what topics you might be interested in us covering in the future. Thank you very much, everyone.